Hello everyone, my name is Abdul Hakim. I'm a consultant hepatobiliary and liver transplant surgeon at Leeds Teaching Hospital NHS Trust. I'm presenting this video abstract for hepatoma research on behalf of my co-authors from the NHS Blood and Transplant Liver Transplantation for Cholangiocarcinoma Fixed Term Working Group. There is growing evidence to suggest that liver transplantation offers a potential for curative treatment for non-metastatic intrahepatic cholangiocarcinoma in patients with chronic liver disease, which is not amenable for liver resection. More importantly, the very early intrahepatic cholangiocarcinomas, which are single tumor less than or equal to 2 centimeter, actually gets the most benefit with a 5-year survival as high as 73% with liver transplantation. In keeping with this, the International Liver Transplant Society in 2019 conducted a consensus conference where they discussed intrahepatic cholangiocarcinoma for liver transplantation and came up with two indications. One of them is the very early disease, less than or equal to 2 centimeter. The other one was advanced intrahepatic cholangiocarcinoma following neoadjuvant chemotherapy. However, the latter does not have much evidence to suggest that there is a definite benefit. The NHS Blood and Transplant Liver Advisory Group formed a fixed-term working group in June 2021 called as the Cholangiocarcinoma Orthotopic Liver Transplantation Implementation Group to discuss this indication. The group was actually formed by the cholangiocarcinoma and liver transplant patient representatives and the experts in cholangiocarcinoma and liver transplantation from various disciplines of medicine. More importantly, the group was represented from all the national professional bodies and also from a few charitable organizations. These are the summary of the guidelines proposed by the group. One of them is that intrahepatic cholangiocarcinoma less than 2 centimeter with background chronic liver disease will be implemented as a pilot service evaluation in all 7 adult transplant units in the UK. A national expert review panel will be formed, which will look into providing the quality assurance that is needed for the pilot study, the overview of the data collection and the management, access for the second opinion if there is required, and also to troubleshoot any pathway related issues, and also will be the reassurance to the patient groups and to the individual centers. Each transplant center will be expected to form a group of core healthcare professionals with interest in managing these patients and complex pathways. Just to take you over the inclusion and the exclusion criteria. So anyone with a less than or equal to 2 centimeter intrahepatic cholangiocarcinomas with a background chronic liver disease, which is biopsy proven, and exclude the mixed hepatocellular cholangiocellular carcinoma, and there's no signs of any extrahepatic disease with the fitness for liver transplant and also signed informed consent. Anyone who is not fit for liver transplant, anyone who who has had a previous liver resection or with extrahepatic disease will be excluded. Just to give you a brief summary of the pathway. Once these patients have been identified by the referring centers, they will be referred to the liver transplant center. They will be discussed in the cancer MDT and the transplant MDT at the transplant center and will be put onto the national liver transplant waiting list on the variant pathway, where it will be expected that they will be transplanted after a prioritization to be within the first 3 months after waitlisting. In terms of the radiological pathway, the primary diagnosis will be with an MRI with Primovist and diffusion weighted imaging. The staging will be with a CT and a PET CT. Surveillance will be on the waiting list. If they're waiting for more than 3 months, then they will get an MRI liver with Primovist and a dual phase CT and a PET CT at 3 months. And post transplant surveillance will be intensive for the first 5 years, with the 6-monthly surveillance for the first couple of years and an annual surveillance until the end of 5 years. So this pilot program has been operational since December 2022, and it is expected that at least 6 to 8 intrahepatic cholangiocarcinomas less than 2 centimeter will be transplanted in the first year. At the end of the first year, it is expected that we'll do a comprehensive national audit to assess the safety, graft outcomes, and oncological results of this pilot program. To gain further information, please visit this website, where a PDF is available with the detailed information, or if you can write to the authors of this manuscript,